Hello friends, today we will be discussing the definition of hypertension. I am Dr. Vimit Kumar, DM Cardiology, Consultant Cardiologist. Now let's have a look at the total hypertensive population in the world. It's 1.28 billions, and out of these 60% of this population is the low and the middle income group countries, and only about 40% are residing in the high income group. Why are we worried about the hypertension? It is important because this is one of the commonest cardiovascular disorder affecting the mankind. It affects the heart, it affects the vasculature, it affects the central nervous system, peripheral arterial disease, and it is one of the important contributory factors for development of chronic renal failure. Now let's see what are the various ways in which we can record the blood pressure. There are four methods to record the blood pressure. One is the patient goes to the doctor and he measures it. This is called office blood pressure monitoring, and all the standard definitions are related to office blood pressure monitoring. Whether it's a diagnosis, it's a treatment, it's to see the effects of antihypertensive medications or any other abnormality which we want to find out from the blood pressure is related to the office blood pressure monitoring system, and this is widely used for the last couple of decades. Second method is when you record the blood pressure in the hospital, but this is being done by the patient himself with the automatic machine, and hospital staff is not there to affect the blood pressure in any way. So this takes care of the white coat hypertensive effect. Third way to record the blood pressure is home blood pressure monitoring. Here the patient records the blood pressure himself. This has an advantage that it spares them of the white coat hypertension. That when you get scared, sympathetic activity increases and there is rise in pressure. So that part has been is taken care of. And now this is becoming more and more popular. Fourth way to record the blood pressure is the ambulatory blood pressure monitoring, where the instrument is tied to the patient's arm and it keeps recording blood pressure at various intervals. So this is done for 24 hours and it records the activities during sleep as well. So because there are certain conditions during which the blood pressure doesn't come down during the sleep, so this nocturnal drip is really missing in such patients like who have diabetes, who have chronic kidney disease and various other autonomic dysfunctions, where this instrument is very helpful. And it also takes care of the white coat hypertension because it is recorded when the patient's natural environment. So here is the summary of all the ways to record blood pressure. One is that office blood pressure monitoring. Second is the office unattended blood pressure monitoring. Third is the home blood pressure monitoring. And fourth is the ambulatory blood pressure monitoring. Now, how do we define blood pressure? Well, if the BP is 120 by 80, that is systolic blood pressure is 120 and diastolic is 80, then this is termed as optimal blood pressure. And if the systolic blood pressure is 120 to 130 and diastolic is 80 to 85, then this is termed as normal blood pressure. And if it is between 130 to 140 systolic and 85 to 90 millimeter diastolic, this is termed as high normal blood pressure. And between 140 to 160 millimeter systolic pressure and 90 to 100 millimeter diastolic pressure, this is termed as grade 1 hypertension. And if the BP is between 160 to 180 millimeter of mercury systolic and diastolic is between 100 to 110 millimeter of mercury, this is termed as grade 2 hypertension, and BP more than 180 millimeter systolic and more than 110 millimeter diastolic is termed as grade 3 hypertension. Now, the Americans consider that any blood pressure more than 130 millimeter systolic and more than 80 millimeter diastolic is hypertensive. So, they have lowered the limit from 140 by 90 to 130 by 80 millimeter of mercury. So, what has happened is that their adult population, which was earlier 32% of adult population was hypertensive, now this population has increased to 45%. And so is their control of hypertensive patients on medication, that earlier 53% of the population was controlled on blood pressure medication. Now this has come down to 39% because of this lowering of blood pressure levels. And the resistant hypertension cases have also increased from 12 to 18%. That is the hypertension which is requiring 3 or more drugs for the control of pressure is termed as the resistant hypertension. So the population has increased just because they have lowered the level of blood pressure, both systolic as well as diastolic. BP levels are highly variable. So this is the reason one has to record blood pressure at different times, at multiple readings are required, because it may be normal in the morning and afternoon time it increases and the night time it decreases. So there are multiple readings are required, and one reading really should not make the diagnosis unless it is very high or patient has associated cardiovascular disorder which necessitates urgent treatment. I think one should know when to wait before starting the treatment. If the levels are between 140 to 180 millimeter of mercury systolic and 90 to 110 millimeter of diastolic, and it's a first reading, we must wait unless it comes repeatedly, or if there are certain cardiovascular diseases which necessitate urgent treatment. Otherwise, we should wait. If the BP is in the grade 3 hypertension, that's 180 to 190 millimeter of mercury, then one can start the treatment straight away. Otherwise, it's worth waiting because of the high variability in the readings of blood pressure. Now let's see what are the goals age-wise. If the normal blood pressure is 140 by 90 millimeter of mercury, then our goal is to keep the blood pressure less than 130 by 80 millimeter of mercury in the patient's age 18 to 64 years of age. And if the patient is more than 64, that's 65 to 80 years old, then the goal of blood pressure treatment would be 140 by 90 millimeter of mercury. And if patient has isolated systolic hypertension and the age group 65 to 80 years, then his blood pressure optimal would be 150 millimeter of mercury systolic. And if patient is more than 80 years old, then we keep the blood pressure less than 150 millimeter of mercury. This is the average levels at which we like to keep the blood pressure in the different age group. Now let's see what is the residual risk. Now if the BP levels are high, say 160 by 100 millimeter of mercury, and we are able to bring it to less than 140 by 90 millimeter of mercury, and the risk which was there when the BP was high, 160 by 100 was 20%, then with treatment the effect comes down to 10%. So even if we are able to bring the blood pressure toward normal, the residual risk of 10% still remains. So this is what is called as the residual risk, and there are a lot of causes for this residual risk. One, that this is the genetic predisposition to the risk of hypertension, because certain individuals are more prone to have complications of hypertension. Second is the late onset. The treatment was started late and the hypertensive mediated organ damage has already set in. Third is the irreversible cardiovascular changes in the structure and function of various end organs are there. So they are not possible to reverse with the present day medicines. Then there would be associated other causes like diabetes or obesity or any other environmental risk factor is there. Then the risk would still remain despite the control of blood pressure adequately. And lastly, it may be the office BP which is controlled, but not the 24-hour blood pressure control is there. And versus the peaks of blood pressure which comes in between because of any reason, they also predispose the patient to have certain risks, which we assume that the BP is controlled, but the risk which remains is called the residual risk.